Okay, online people, can you hear me and see our slides? Would you please put a yes or a hello or something in the chat for me? There we go. Fantastic. Do you want the chat up during your presentation, or would you prefer to answer questions at the end?
I probably prefer it at the end, probably.
Okay, sounds good.
Yeah.
So online folks, Dr. Tess Smith will get your questions at the end. So feel free to pop them in the chat whenever they occur to you, but she'll get them when she's done. All right, fantastic. Our next speaker is Dr. Tess Smith. She is our board certified neurologist and neurosurgeon. She's going to talk to you about neurologic lameness in dogs. Just make sure this is going okay. Yep, so just you can advance either here or with those arrows there.
Got it. Okay, excellent. Thank you, Heidi. Hi, everyone. I'm Tess. Today we're going to be talking about neurologic lameness and specifically dogs. I don't want to neglect the cats in the room, but we're going to talk about dogs today. And I want to talk about this topic. Ooh. And let's see, how do I? Oh, got it. At the pointer? Yeah. That's all right. That's not a huge deal.
We can get rid of the laser pointer. There we go. Do you want me to pause it?
Yeah.
Okay. That is.
So, because, you have a dog come in your clinic, they have this left forelimb lameness, and this could be orthopedic or neurologic is the tough thing. A lot of times when you have a dog come in, you're going to be worried about orthopedic disease, but theoretically they can look very, very similar. And how can we use clues on our exam, on our history to kind of suss out, where are we going to localize the cause of this lameness? So we'll talk about just kind of a couple definitions. We'll do just a brief anatomy, and then we'll talk a lot about clinical approach, so history, how can we use our exam, and then just some common differentials that we should be thinking about when we are kind of narrowing it down to say, okay, we think this is more of a neurogenic or neurologic cause of lameness. So with lameness, so we'll just define it. It's an abnormal gait caused by dysfunction of the locomotor system. Typically, they're short-strided in the affected limb. They're a little more long-strided in the contralateral limb. And again, this could be orthopedic or it could be neurologic. We also have monoparesis, which is a little different than lameness, but sometimes when it's mild, it can look a lot like a lameness, or we can have like a lameness and a monoparesis both going on at the same time. So that's decreased motor function of a limb. Usually they can't support their weight very well. They can't generate their gait normally. And that's always going to be, neurologic in terms of underlying causes. But again, when it's mild, it can look a lot like an orthopedic lameness, frankly. So anatomy a little bit. So these are the brain and the spinal cord segments. So we have C1 to C5. We have C6 to T2, excuse me. We have T3, L3, L4 to S3. And usually when we're talking about lameness, we're talking about most commonly an issue with either C6 to T2, the peripheral nerve, L4 to S3, or the peripheral nerves. Now, sometimes you can have a T3, L3 lesion or a C1 to C5 with a lameness, but more commonly we're talking about these intumescences and then the nerves as they exit that intumescence. So specifically, I circled, oftentimes if this is a problem outside the spinal cord itself, it's usually involving the brachial plexus right as it leaves the spinal cord. So we're talking about our suprascapular nerves, our subscapular nerves, musculocutaneous, axillary, radial, median, ulnar. These are all this is kind of a nice diagram that kind of shows what everything innervates. But for your clinical exam, you'll just want to keep in mind that when we're trying to get an idea of, well, is this a nerve dysfunction? Radial nerve, it's going to control our extensor muscles. ulnar and medial nerve, going to control our flexors. And then this is just our pelvic limb plexus. So with our femoral nerve is one of our big ones. We have our gluteal nerves, our sciatic, another really big one, our pudendal and our obturator nerves. So we're going to talk a lot about clinical approach, history, exam, and just sort of how we kind of work through these patients. So clues on the history. So typically, if the lameness or weakness gets worse at slower speeds, it tends to be more neurologic. If we feel like activity makes this worse, you should be thinking more orthopedic. Or if we have something where the lameness is worse when you're going from resting to active, it gets better as they get more active, you should think orthopedic. While lamenesses with an underlying neurologic cause can kind of wax and wane with certain activities, it tends to be less so. So if it's consistently there at a very slow speed, you should think a bit more about neurologic causes. Of course, if we have things like scuffing of the paws, abnormal nail wear, sores on the toes and the pads, you'd be thinking more neurologic as well. And if it's hard to see in the clinic, or especially if it's intermittent, get a video. Thank goodness we have that capability now, getting videos of when the dog is most affected, because oftentimes they're more affected at home after they're doing certain activities. So spinal pain. What are signs of spinal pain? Certainly this picture is this dog has a low head carriage. It's lifting its left thoracic limb, but sometimes they're not quite as obvious as this. But you should be thinking about if you have on the history yelping. We don't see that a lot with orthopedic disease. Maybe right after a specific injury, but intermittent yelping, whether it's with or without stimulus, tends to be more of a neuropathic pain response. Reluctance to jump or climb. I put an asterisk by that because, bilateral cruciate disease can also cause that. So that's a tricky one too, but that can definitely be a clue though, if it's like, well, they just don't want to, they're reluctant to jump on the couch. A lot of times dogs with like one cruciate, they'll still try to, move around and jump and things. But if it's bilateral, you do have to be careful with that one. But reluctance to jump or climb is one. Arching of back, certainly low head carriage, or maybe it'll be more subtle. Like you'll notice owner will say, well, just having trouble, doesn't want to drink out of the bowl when it's on the floor, prefers it to be raised. That can be a subtle sign. Certainly tense neck, bag, abdomen that the owner notices when they touch the dog. If they're restless too, if they just seem like they can't get comfortable, that's another one. And then, of course, intermittent lifting of a limb when just kind of standing there, which we can see with orthopedic disease as well, but that's very typical with the Schnauzer. He looks so painful. His left thoracic limb, he has a typical like nerve root signature there. So what about our exam? It's really important to keep in mind, though, that most lamenesses are orthopedic. So we should always be thinking about orthopedic, until proven otherwise. It's true that neurologic lamenesses are less common. So one clue is going to be you're palpating the limb and you don't get any pain on the limb itself. Now, sometimes this is tricky, especially when they're standing, you're doing an exam. Sometimes what I'll do is I'll put them in lateral because, if you're standing and you're palpating a caudal lumbar spine or setting a hip, it's all referred, it's all in the same area. And if they're bearing weight, it can be a little hard to isolate. So sometimes I'll actually put them in lateral if they're amenable to sort of if I can isolate specifically spinal pain versus hip. Certainly severe muscle atrophy. So certainly if a dog's been limping for 6 months, you're going to have some disuse atrophy if it's orthopedic. But if it's more neurologic, you should be thinking if this muscle wasting is occurring over days or even just 2 or 3 weeks and it's pretty dramatic, you're thinking more neurologic as well. And then, of course, abnormal neurologic exam. So we're going to talk now more about what are some clues on our neurologic exam we should be looking for. So as we talked before, that definition, that monoparesis, decreased motor function of a single limb, looking for paraparesis. So that is decreased motor function of both pelvic limbs, tetraparesis, decreased motor function of all 4 limbs. So the gait, when you're doing a gait assessment, it really should be assessed at a couple different speeds if you can, both at a walk, also at a trot. And so, because different speeds can just kind of bring out more obvious lamenesses, especially if we're talking about, hey, neurologic disease is more obvious when they're going more slowly. So it is a skill to be able to walk a dog appropriately, because you don't want them pulling, you don't want them veering left and right. That can be really difficult. And so typically, and when we're talking about paresis, we're talking about scuffing, we're talking about them not picking up their limbs and putting them through a full range of motion, they're shuffling, or they just seem to they get tired, they fatigue in one of their limbs after gait assessment. Oh, and this is an example of a dog with, a monoparesis. Now, this is certainly a pretty severe example of a monoparesis.
I just need him to walk a little bit. Come on, buddy.
But you'll see he's moving that limb. He has motor function, but it's not normal. He's not putting that, through a normal range of motion. And he's also not able to stand on that limb, and he's not just able to put really any weight on it at all either. So this is a pretty typical monoparesis, when they're just not able to move that specific limb normally. He's just kind of dragging along. He can put weight on it, but not very much. Next step, proprioception. Super important. You have to be careful though. I've been fooled before too. So sometimes pain can cause, I would say, abnormal conscious proprioceptive test. Sometimes, so you have to be careful with this one. Certainly if I have a history of scuffing, if I see wearing of the nails like I do in this picture on the right, and if I get a deficit in a limb without any limb pain, then I'm much more likely to believe the deficit. But it tends to be a hallmark. You just have to be a little careful with interpretation sometimes, because if their knees are really painful, they may just not want to lift that leg very much. It's also important to support their weight really well, so that they don't have to. You're more likely to get a false positive, I think, if you're not supporting them. So really supporting them, so kind of take as much weight off of them as possible, so you can try to eliminate pain if you can. So cranial nerves, cranial nerves most of the time aren't going to be helpful, but there is one thing with the face we should look for, and that's anisocoria. So, I outlined this Horner's pathway, which you can see in the brain on the CT scan. That's the red dot. You follow that red line down through the cervical spinal cord. This pathway exits at T1 to T3, and then it goes into the chest, up the vagosympathetic trunk. So if you have a lesion anywhere in your cervical spinal cord, especially at the C6 to T2, that's that intumescence where we are more likely to see lameness as the manifestation of a C6 to T2 issue, you can totally have Horner's. So making sure and specifically anisocoria more than anything. So looking at those pupils and just seeing, is there a subtle difference between those two things? And you'll see meiosis, so small pupil on the affected side. That's important, subtle trick too. Another important thing is spinal reflexes. So, in our thoracic limbs, we're going to be looking for our withdrawal reflex, which tests a whole host of those nerves I have listed there. Pelvic limbs that test the sciatic nerve. This picture shows testing of a biceps reflex, which you can kind of learn how to do as well. Biceps reflex and triflex reflexes, they're not always as reliable. So, you really want to rely on withdrawal reflexes. Also, I listed your patellar reflex, which tests the femoral nerve. That's also going to be another important one. A little caveat about the patellar reflex. So dogs over the age of about 9 we suspect that that can be a normal finding for them. So interpret that one with a grain of salt too in a geriatric dog. Another sneaky one is the cutaneous trunki reflex. So I again outline kind of where this sort of reflex goes. So you stimulate, you're stimulating way in the back, of course, kind of just cranial to the hips. And you should, that's the stimulus. And then that pathway travels all the way up. And in order to make that twitching, that whole body twitch happen, it has to go all the way up to C8 to T1 spinal cord segments. And then the loud thoracic nerves exit there and does that whole body twitch. So if you have a lesion, again, if you have a forelimb lameness and you're worried about a C6 to T2 issue, you could also not have a cutaneous trunki if you have a lesion at C8 to T1. So that's another sneaky thing to just that you wouldn't thing to check, but check that. You just never know. That could give you a little bit of a clue because that may not be there on the affected side. Spinal palpation. So we kind of touched on, palpating a hip versus called a lumbar spine, trying to isolate those two things. There's, of course, shoulder versus caudal thoracic, which can be tough. Excuse me, I meant caudal cervical. Anyway, and then, excuse me, abdomen versus TL spine. So this picture on the bottom, you're putting a hand under the abdomen, and you're sort of trying to see, are we seeing more tensing of belly versus back? And again, sometimes putting them in lateral can be helpful for that too. And I also outlined, so this picture on the left shows palpating the cervical spine. Definitely recommend palpating more ventrally to look for cervical pain. If you palpate more dorsally, you can miss a lot of cervical pain. There's just so much muscle up there. So palpating more ventrally, there's less muscle there. You're more likely to get cervical pain if you palpate more ventrally. And sometimes I even go a little more ventral than what she's doing. But yeah, so that's an important way to palpate the cervical spine. And certainly sometimes it doesn't exist in a vacuum. Like dogs accumulate many things. So sometimes we have orthopedic and neurologic disease. Both can be present. And so we do have to do some sussing out of, well, which is more clinically relevant right now. Do I have a dog with a chronic mild hip dysplasia, but their back pain is their true current issue? Okay, let's talk about a little testing. Let's talk about some common diseases that cause neurologic lameness. So radiographs, it's such a nice tool that you have, and you can evaluate the orthopedic system that way pretty well. And of course, when we have a lameness, we are going to be thinking orthopedic disease is more common. So using radiographs is great for that. It's, of course, not very helpful for neurologic disease. It's very uncommon that we see the problem on radiographs. Sometimes we'll see things like spondylosis, but that's usually actually not relevant to what's going on. That's there, in some very occasional situations that can cause some pain, but there's usually more of the story than the spondylosis. And of course, we're going to be interpreting radiographs in light of clinical signs. So again, does that mild hip dysplasia on radiographs fit with this patient's clinical signs, or do we think there's something else going on here? And of course, radiographs are great too, because they do help document orthopedic disease. Because again, even if we're worried about neurologic disease, if we're going to be managing something that's neurologic, it does help with expectations for recovery, for management, if we know we have concurrent orthopedic disease, because they like to make each other worse sometimes, and can make sometimes like recovery from maybe a surgery might be a little bit more different if we have a lot of orthopedic disease going on. So we'll talk about a couple of common, differentials. One is going to be the lateralized intervertebral disc herniation. And this is pretty, you want to think about chondrodystrophic breeds for this. young to middle-aged dogs. So segment's important for this one. For example, if we have a 3-year-old dachshund who comes in with a lameness, acute onset lameness of a thoracic limb, let's say, we should be having neurologic cause of lameness, especially this thing, on our list, because the chance of a dachshund having, like an elbow issue at that age is really uncommon. That's a low prevalency. In contrast, if we have a lab come in who's 3, and he's got a thoracic limb lameness, it's almost always going to be the elbow, actually. So that's important, is signalment and age for sure. But with this intervertebral disc herniation that's lateralized, and I'll show you a picture of it too, acute pain, very common feature. They oftentimes just seem really uncomfortable at home, but you can't really localize their pain on exam. And yeah, they may or may not, like a lot of lamenesses that are neurologic, they may or may not have proprioceptive abnormalities. Radiographs usually normal, and then we're at the MRI stage. This is Tommy. He was an 8-year-old poodle mix, and he had a 2-month history of this right pelvic limb lameness. So, his radiographs were unremarkable. His first exam, they thought they got some pain on stifle hyperextension. They were worried about his cruciate. They did a repeat exam. They didn't get it that time, but then they kind of thought maybe you're painful on your hip and maybe you're caught a lumbar spine as well. It came to me. And at this point, he had progressed a little bit, but he had an intermittent, it wasn't all the time, an intermittent right pelvic limb lameness. He was shifting off weight off this limb. He had mild pain on hip extension, but I felt like the pain was worse in his caudal lumbar palpation. He had very mild deficits of both pelvic limbs. And this is an example of a dog who sometimes it takes you a while to get to this place where you come to the neurologist, because these are really tricky. And sometimes it also illustrates the importance of just repeat exams to just try to suss out, how are things progressing? Are we still getting stifle pain? No, we're not, and things can evolve as such. So, and I had the luxury of getting him, a couple months into this where he had, progressed a little bit, but he definitely had some atrophy on that side as well. And he ended up having this is a lateralized, on the left, this is a lateralized disc extrusion. So I don't have the pointer, but let me see if I can turn it on actually. Let me just laser pointer. So this is our disc where it normally sits. This is L56. And so these little black dots, these are our nerve roots as the spinal cord ends. And this guy right here, that's the disc, it popped out that way instead of going up. So, and when you have a disc sitting out there, it's not going to cause any ataxia. It's going to cause pretty minimal, if no paresis at all. It's just going to cause a lameness and pain. Let me see if we can look at Tommy here. Your pointer. And yeah, so he did very well with surgery. These guys like immediately feel better. So he was a lot happier. And so when we have a lateralized disc herniation, kind of like, our typical disc, we're going to talk about medical management versus surgical management. These guys with their lateralized disc herniations, they do have a high success rate with medical management, I will say, based on some, more recent investigation and literature on this specific type of disc herniation. You're going to want to use a neuropathic pain medication. I actually prefer pregabalin over gabapentin. I think it works better. It's just not as available, but I like that one a lot more. An anti-inflammatory, I tend to find anecdotally the steroids work a little better for these, but a recent study showed that, of the dogs that got better with medical management, half of them were on carprofen or were on an NSAID, and only a third of them were on steroids. So, I think it's still appropriate if you're suspicious of this to try carprofen or an NSAID to start. That's completely reasonable. Of course, in rest, I always do 4 weeks of rest. And about, 95% of dogs need surgery, have a good outcome if they need that. But yes, we recommend it if there's no response to medical management. Maybe they get better for a while, then they relapse. So that's usually how we approach these specific type of disc herniations. And they're pretty much always at L5, L6 or L6, 7. And usually 92% of these dogs that had this condition, you know, they had pain, and then about 70% of them had a lameness too. So very commonly they're just painful and they're lame on one limb. Brachial plexus avulsion. So this is, you know, injury from significant either traction, tension, you know, laceration of multiple nerves of the brachial plexus. You know, neuropraxia describes what a conduction block, but the nerve is intact. So meaning that the nerve has been stretched, there's an issue with transmission of signal, but the nerve is still, it's fully intact. Axontemesis, it means that, you know, the myelin's intact, so the outer sheath is intact, but you've got some axons sitting in there that are torn in some way or traumatized. And neuromesis means that the entire neuron, the nerve, is not always transected, but at least torn, where that myelin is also affected. And neuropraxia, axontemesis, most of those guys will recover. Neuromesis, when you have more of like the full nerve is torn or transected, those prognosis a lot more guarded. But we'll talk about in a couple slides how to prognosticate these patients. Oh, that's right. We had so for the majority of these patients, I was just curious, do you guys use steroids or NSAIDs for intervertebral disc disease? Steroid? It seems like maybe steroids are winning the oh. Okay, so I feel like we're getting kind of a 50-50 split here, which is reasonable, actually. The most recent consensus statement on disc disease actually recommended NSAIDs slightly over steroids, but there's still justification for steroids. So really the bottom line is, you know, if you're worried about orthopedic disease, start with NSAIDs and then try steroids if you're kind of thinking more about, okay, maybe this isn't an orthopedic condition. So, and I also wanted to bring up that point because, you know, these dogs with this lateralized disc herniation, like half of them that got better, they were on NSAIDs. So I think that either is completely appropriate. And I think it's reasonable if you're worried about more of a lameness is to start with NSAIDs, you know, so. Brachial plexus avulsion. So usually significant trauma has occurred. Car, most common. The second most common was falling from a height, and then third, kicked by a horse. Yikes. And on an exam, this is a very typical stance for a dog with a brachial plexus avulsion, where they're not able to extend their carpus, maybe their elbow. That usually means the radial nerve is affected because the radial nerve is important for our extensors. They may or may not have decreased spinal reflexes. They definitely we want to be evaluating for motor function and pain sensation distal to the elbow to get a better idea of prognosis. They may have anisocoria. And again, that sneaky may or may not have a cutaneous trunci as well. This is Sunny, actually, we saw probably about a year ago, who initially got hit by a car, so pretty typical, non-weight-bearing right thoracic limb lameness. They did get some soft tissue like right carpal, right elbow pain, but radiographs ended up being unremarkable. The dog had some mild anisocoria, had a mild pneumothorax. When she came to me, she was doing this. So watch it a little bit. And again, this is a nice example of a lameness and a monoparesis at the same time. There's a lameness, and she's also just not quite able to put that right thoracic limb through a normal range of motion.
One more time.
She had some myelonicoria. She had no spinal pain. She had absent proprioception of the right thoracic limb, which is the limb affected, but no other limbs were affected. So when you see a dog with this kind of posture, this monoparesis after a significant trauma, of course, you're going to do radiographs to look for other injuries. Do we need an MRI for this dog? So if you're getting deficits in any of the other limbs, if you're getting some spinal pain, then totally reasonable. However, if you're not getting any neck pain, and I would say we should think about this a couple days after the injury when we've had time to treat kind of more of a soft tissue component to this. But if you're not getting persistent spinal pain, you're not getting any other issues with any of the other limbs, it's actually probably not needed, because this is the way this presentation is very typical. Electrodiagnostic is something that sometimes we as neurologists offer too, but it's actually been shown that it's not more helpful than our exam. So back to the basics, where our exam is most important, which leads me to prognosis. And that's what we're all about, right? Is this, what's a prognosis with a dog like this? And if they have no pain perception of that limb, so if you use hemostats, if you pinch that toe, that foot, they may withdraw, right? Because that's a reflex. We don't care about the reflex. But if they're not showing a pain perception, they're not looking at you, they're not yelping, then that is associated with a poor prognosis. However, definitely give them a month, because if they get pain sensation return within 4 weeks, then they're probably going to be okay. It's probably just going to take a while. But if you are 4 weeks out and there's still no pain sensation, then I would say we're talking about a limb that's going to make not a complete recovery. If any, we might be talking about amputation at that point. And then, of course, using neuropathic pain meds is helpful. And yeah, lots of time. So the axons regrow, 1 millimeter a day. So if you think about like a large breed dog, in the length of their limb, it could take them 6 months to get back themselves, maybe even 6 to 8 months even. So it takes a while. So as long as we have pain sensation, if we have motor function like Sunny did, even better, giving them lots of time, and it is normal for them to take quite a bit of time. Another differential thing about is the dreaded peripheral nerve sheath tumor. So these are tumors of the Schwann cells or any other tissue surrounding the nerve. The Schwann cell makes myelin. We also have these sort of soft tissue kind of structures around these axons, and we can also get a tumor from those tissues as well. Yeah, these are oftentimes more slowly progressive lameness, and they're kind of insidious. They're really tough to pick up initially. So we tend to diagnose them when they're, later on, because they're very subtle in the initial stages. On a neurologic exam, we're going to see significant muscle atrophy. So over, a few weeks and not many months. Important thing, palpating the axilla, because sometimes you can get axillary pain or a mass. Like 30% of the time, I believe, we suspect you can actually feel a mass in there. And it might be painful, or you may just get pain alone. So that's a clue if you can find a mass and or pain in that area. And looking for other proprioceptive deficits in other limbs is important too. And, of course, we're going to look for any ataxia or paraparesis that's going along with this lameness as well. And the picture on the right, that's an MRI. That star is going to be our mass. And let me use the laser pointer again. This is our mass. This is our spinal cord right here. Oh, I didn't get it right there. And, a dog like this, if you are getting proprioceptive deficits in the other limbs, I automatically, before the MRI, worry that this tumor is probably encroaching into the spinal cord like this tumor is, where it's pushing on the spinal cord. And that's just important for treatment, which we'll talk about in the next slide. So that leads us to amputation is usually not enough in these cases because, you know, if we amputate, we're going to leave all this disease behind and it's going to keep growing into the spinal cord and cause weakness in the other limbs. So then we're talking about amputation plus either a hemipelvectomy, laminectomy. These are pretty aggressive surgeries, but they are options. We're talking about radiation. And, you know, with these advanced treatment options, you know, up to 20% of these dogs are surviving into 2 years. So it's a devastating one, but there are options. Sometimes you can just radiate them and not put them through, you know, the surgery, which is also reasonable. We have people do that too, just at least for palliative care, for pain control. That can also be a benefit. And then I mentioned palliative care. You're going to want to use steroids for this one. You know, even though steroids can cause some muscle atrophy, you know, it's going to just, I think, help a lot more with pain and function, at least temporarily. These guys, they often become painful and their pain control can be tough. I will say that sometimes ends up being a big quality of life ending situation is because they're just really painful. So. And then finally, our last one is a neuritis, which can look so similar to peripheral nerve sheath tumor. Again, it can be one thoracic limb is lame, you've got a lot of muscle atrophy. You do want to, if you don't get pain in the axilla, I mean, it's very uncommon that we get axillary pain. You shouldn't feel mass or anything like that in this situation. It can affect any peripheral nerve, but of course, cervical or lumbar nerves, that those intumescents are most common, and they're the ones that are going to cause that lameness. And yes, a neurologic exam, again, very similar to the nerve sheath tumor. So, you know, there is a chance that it could be not a tumor, I guess, when you see this presentation, that it could be something more treatable. So radiographs, again, will be normal. This is an example of a weird bilateral neuritis where you have really big peripheral nerves on both sides, but that's what it looks on an MRI. And it's pretty much always immune mediated. So, and it is a pretty good prognosis. So it's infectious causes other than a weird migrating foreign body have not been reported. There was some weird report of a mycobacterium in a cat, but I wouldn't, you know, hone in on that too much. And we're going to use immunosuppressive steroids is what you use, plus minus other immunosuppressants as needed. But these dogs typically do well. Sometimes they need long-term medications, whether it's low-dose steroids or, you know, a concurrent immunosuppressant drug, a long-term, like some of our other brain or spinal cord autoimmune patients that we have. So kind of things to take away. If we have a dog with lack of pain in the limb, if they've got a proprioceptive deficit, they've got a lot of muscle atrophy, this can help us determine orthopedic versus neurologic disease. You know, most commonly, we're going to see orthopedic as the cause of lameness. Both orthopedic and neurologic disease can be present, though, especially in an older dog. So trying to figure out what is more relevant at this time. And then if we are worried about saying, hey, this is probably neurologic, we're going to think about lateralized disc disease, we're going to think about neoplasia, and we're going to think about inflammatory or neuritis is actually more appropriate as common differentials. And then you do want to think about the brachial plexus injury, but only if there's been a significant trauma history at this point. Okay, that's all I have. Any questions? Oh, let me look at the chat. Oh, what is my washout recommendation between steroids and NSAIDs? Yeah, so if it's kind of more that they have been on, let's say, the NSAID for maybe just more like a couple weeks, maybe less than a month, I usually do about 3 days in between. So 3 days with nothing, and then I'll start the steroids. If it's more of a chronic, like, hey, my dog's been on carprofen for more than a month, many months, for a concurrent other orthopedic issue, I usually try to give them a week if possible. Now that's tough because if they're really painful, you don't want them in pain. But trying to maybe bulk up some other pain meds during this period when they're off, when they're between NSAIDs and steroids. Sometimes I will bite the bullet early and I'll just cover them with omeprazole and, plus minus sucralfate if we can. Okay. What is the prognosis for a suspected orthostatic tremor condition in a giant breed young dog? So this is an orthostatic tremor. It's basically a tremor that is present only with certain postures. This is typically a benign condition. Great Dane is the most common example, but this is typically a benign condition. So even if it's persistent, as long as we're not seeing any other neurologic abnormalities on our exam, that's a good prognosis because it's almost always benign. Okay. I think that's it. Thank you guys so much. Oh, I thought, yeah, I was like, I was expecting you to raise your hand. Do you guys have questions for me? Okay,
No,
great. Okay, sounds good. Okay, perfect. Thank you.
Yeah, thank you. All right, I'll take your mic back. All right, online folks, we will get started again at 11:30. Take a 15-minute break here. Thank you.